Hello, my name is Ian McCollin. This is the video overview of Module 7a of the Derm Consult course. These are the various topics that will be covered in this module, notably psoriasis and its variants, and there are many variants of psoriasis. Remember, when you're faced with what looks like an unusual rash, it may, rather than being an uncommon rash, it's more likely to be an unusual variant of a common rash. So it pays you dividends to spend some time looking at the various variations of presentation of psoriasis. I mean, the classic variations are the plaque psoriasis in the body and with it's red and scaly, and the flexural variant where, because of moist occlusive surfaces, you don't get the scale. But you've got this presentation of psoriasis in the scalp, you've got pustular psoriasis, you've got erythrodermic psoriasis, you've got localized pustular psoriasis in the palms of the hands and the soles of the feet, you've got psoriasis presenting as keratoderma of the palms of the hands and the soles of the feet. So you've got to be familiar with all of these variations. This module also looks at the conventional therapies for psoriasis, and there is a section in here on the biologics as well. These are the new monoclonal antibody drugs which have a dramatic effect on suppressing the inflammatory processes that are involved. The processes of inflammation that are involved in psoriasis are much the same as those that are in conditions such as ulcerative colitis, Crohn's disease, rheumatoid arthritis. And there are various cytokines, particularly tumor necrosis factor alpha, which are prominent in the inflammatory cascade. Now, these biologics some are derived from a combination of human and mouse proteins, some are pure human proteins, monoclonal proteins that block or either bind to the tumor necrosis factor alpha or bind to the receptor and block it. And it really shuts off the inflammatory process in psoriasis. So they're really remarkably good drugs, but very expensive. This module is also going to look at pityriasis rosea and pityriasis versicolor. Pit rosea has a whole variety of variations. There are hemorrhagic varieties, there are blistering varieties described. Watch the atypical pityriasis rosea. It often lasts certainly up to the 12 weeks that we usually give as the cutoff point for this particular viral rash. And watch the variant that's known as inverse pityriasis rosea, where you get the rash, typically the same red, slightly scaly rash, oval-shaped, but you see it confined to the axilla and the groin. We'll look a little bit at lichen planus, although this will be covered in more detail in one of the later modules. Dermatoscopy is going to look again at vessels and also at the clues to melanoma. We'll look at those in a minute, as a little tutorial on ulcers. In the actual webinar itself, we're going to look at these difficult areas of psoriasis to treat: scalp, nails, hands, and feet. Some difficult types of psoriasis, the erythrodermic, pustular, psoriasis in pregnancy, pediatric psoriasis, and fairly florid psoriasis you can get in HIV disease. We will deal with the biologics in the webinar. We'll specifically look at the dermatoscopic clues to melanoma because that's the one bit of this that I think is very important. And there's a nice clinical case of oncoudasaba, one of the variants of morphea. So look at this video. It will go into all of the various presentations of psoriasis, or at least most of the common ones. DermNet has a lot of good material on psoriasis, on the individual areas as well, so it's worthwhile flicking into the DermNet site and looking at those. This slide here looks at inflammatory psoriasis. If you've got a stable psoriasis and for one reason or another the patient comes in and complains that the psoriasis is flaring and this is painful, look very carefully at it and see if you can see any signs of pustules, because that's an unstable type of psoriasis and you've got to handle it differently to handling other types. You basically back off as far as treatment goes, rest them, give them moisturizers and a bit of 1% hydrocortisone cream and wait and hope that it'll settle and not develop into a really florid pustular psoriasis. If it does, you're on to methotrexate. If you've got it type, the various nail manifestations of psoriasis, so certainly look at them. Psoriasis is such a common disease that you really need to know lots and lots about it. Also, by the way, this was a little podcast that I did on the biologics. You might want to listen to that. It's a little bit dated, this, nowadays. You want to know a little bit about the PASI score, the Psoriasis Area and Severity Index. And it really looks at, as the name says, the areas of the body that are involved, how red they are, how scaly they are. And there are various formula used that you can put together to get a number. And with the biologics, you have to have a PASI greater than 15 to qualify for these immune drugs. And it has to show a 75% improvement after 12 weeks to be able to continue. So your PASI is going to have to drop to somewhere between, I don't know, 3 or 4 to get a 75% improvement. Phototherapy has always been a good modality for psoriasis, so worth reading these particular topics and have a look at this one. John Hawke was a professor in Dundee, I think. Was he in Dundee? No, he wasn't. John Hawke was in London. I'm just trying to remember who the very famous professor of photomedicine was who was at Dundee University. It'll come to me. Here's a more detailed lecture on psoriasis and the biologics. You know, these drugs are becoming important, so you really should have a little listen to this. You've got to have an idea about the nature of these drugs and any problems that may arise from them. We're still finding our way with them, but some of these drugs now, we've got out to 5 years of usage and 5 years of safety data, not just in psoriasis, but in the other inflammatory diseases. So it's likely that it will apply to psoriasis as well. What else do we have? Psoriatic arthritis. Remember, nail disease is often a surrogate marker for someone who's predisposed to psoriatic arthritis, and the degree of psoriatic arthritis isn't related to the degree of skin involvement. And some people have very severe arthritis. It can affect the hands, and you can get a picture that's almost like the mutilans variant of rheumatoid arthritis. But typically it affects the larger joints of the ankles and the knees. Reuters you should look at. It has a couple of characteristic presentations on the soles of the feet and on the penis, with Keratoderma blennoragicum being the name given to the almost pustular psoriasis-like picture on the soles of the feet and the palms of the hands, and succinate balanitis being the name given to the curious circular, circuitous patterns of scaling that you get on the surface of the glans penis. What else is there? A little bit on TARS there you should read up about. We don't use them as much. Just some summaries there. The dermatoscopy topic in this module looks again at vessels, and there are patterns of vessels here courtesy of Alan Cameron and Cliff Rosendahl, who illustrated this pattern of vessels. There's a slide here that looks at the types of vessels that you'll see in various lesions. I find that most useful vessels, if I'm differentiating between superficial BCCs and SCCs, you'll get these coiled vessels, the dot-like vessels in SCC in situ, whereas you'll get the linear, sharply defined linear vessels in a superficial BCC. Vessels can also be useful in melanoma, especially the pure kind. I think we've got an example. These are, by the way, are the sharply defined linear vessels in BCCs. Have we got? There's some looped vessels here. You'll see at the periphery of these keratin areas, particularly in keratoacanthomas and SCCs. By the way, there's these dot vessels that appear to be, like a string of pearls. They're part of a clear cell acanthoma, usually presenting as a pinkish nodule like this on the trunk or on the lower legs. I thought we had, we don't have a picture of any melanotic melanoma there for vessels. I thought we did have. Well, generally, this central portion here is like that. You get a variation in the vessels. You may get some little dot vessels, you may get some linear vessels, you may get a corkscrew vessel. I don't know if this will enlarge, and we can have a look. No, it doesn't enlarge much. But it's the varying pattern of vessels in this that can help, especially if you've got a completely amelanotic melanoma. So read through that, have a look at the video. And then there were the clues to melanoma, chaos and clues. You look at a lesion and you ask, is it chaotic in terms of its structures or its colors? If it is, then you look to see if there's any clues to melanoma. These are the clues. Thick lines reticular or branched, especially peripherally. So here you've got these thick lines peripherally. Enlarge this and have a look. But you've got the reticular, a net-like pattern with thickened, darkened lines here. Lines parallel ridges. This is on the soles of the feet. Lines radial or pseudopod segmental. This is usually streaks at the edge of a growing lesion. So if we have an example, these are, by the way, lines parallel ridges. You've got some streaks in the outside of this area here, but you've also got pseudopods, and that's one of the other markers here, pseudopod segmental. Grey or blue structures, grey dots, they're probably the least specific clue to melanoma, because grey dots just represent melanin and melanophages in the dermis, and you'll get that as part of a regressive process, but you get it as in LPLKs, you'll get it in other medical conditions like lichen planus. Black dots are clods peripheral, especially if there's variation in the size of the clods. This tends to represent rapidly growing nests of cells. Eccentric structureless areas where there's no structure and it just seems like a big bite's been taken out of the lesion dermatoscopically, especially if it's white, if the color is a lot lighter than the surrounding color, then it's a clue to melanoma. White lines are a clue. They represent part of the collagen structure of the lesion. But I mean, white lines aren't specific. You'll get them in a variety of other lesions as well, including Spitz nevi, including BCCs even. But look for them, and you'll also get them, I think, in some dermatofibromas. But look, because of the collagen in the center, but look for them especially in desmoplastic melanomas. Then we talked about polymorphous vessels, especially with associated dot vessels. And the other thing, Scott Menzies, one of his clues, varying shades of pink within a lesion, especially if it's a virtually colorless lesion anyway, then various shades of pink can be clues to melanoma. Have a little look at that and listen to that video. It goes into all of these things and goes through all these various images. Yeah, I think this was the one that was the amelanotic melanoma. It's just enlarged that a bit. You need to enlarge it a bit more, but it helps to point to the different types of vessels that are seen in an amelanotic melanoma. What else did we have? Little thing on tutorial topic on ulcers. It's difficult to get a mnemonic that works for ulcers. There can be obviously a whole variety of reasons, from trauma to neuropathic ulcers to ulcers due to tumors, ulcers because of surrounding disease, the pyoderma gangrenosum, decubitus ulcers. So have a little read about that, and a little thing there on pyoderma gangrenosum. By the way, we did a PDF here on methotrexate. Methotrexate is a drug we use a lot in dermatology, so you should know a lot about it. It's still a very useful drug. Because it's been around a long time, it's a very safe drug. We know how to handle it. very effective in pustular psoriasis or in marked plaque psoriasis. Just watch patients who drink have got liver problems because it's partly metabolized there and it's partly excreted in the kidneys, so you've got to watch the kidney function as well. And this is a case that we'll cover in the webinar, the Oncuda-Sabra variant of morphea. Here you see it here, often a bit of a ridge, firm area here, and this can go down all the way almost to the bone and up into the scalp, causing hair loss as well. So it's quite an aggressive form of morphea in some children. And in the webinar we'll go into how you diagnose this and how you treat it. So there's a lot in this particular module. Spend some time looking at the dermatoscopy. Certainly look at the clues to melanoma there, the various things on vessels again, and try and spend time looking at all of these various links that are here in psoriasis and get a chance to read or listen to the lectures on the biologics as well. Thank you very much.